You guys, I'm just going to say a few words about a model of care in Alberta, and I won't talk for very long, and hopefully Andrea Warman, who's the TB elimination nurse for FUNIB in Alberta, will join us, and possibly Courtney Heffernan, who's the manager of our TB program evaluation and research unit, might say a few words as well, because she's been doing some work that relates to physician education, whereas Andrea will say some words about nursing education. But at any rate, you guys, we have a virtual clinic model of care in Alberta, and it's really a mixed model. Historically, in the province, there were two programs, the TB program of Northern Alberta and the TB program of Southern Alberta, and the line was through Red Deer, and the two programs didn't really connect very well, and it was really back in 1998 or 1999 that FUNIB and the province, I was very involved, as well as the nurse manager, Elaine Benjamin at the time, John Waters, the medical officer of health, and David Strong, who was the MOH for FUNIB at that time. We all worked together at basically changing it to a 3-compartment model. So basically, the idea was that Calgary would have its own outpatient clinic, Edmonton would have its own outpatient clinic. These are sort of traditional outpatient clinics. And then Edmonton would have a virtual clinic that basically served all of rural Alberta. So, this model of care, you guys, was established in 1998-99, and it united the separate rural components of the program by providing centralized expertise to sparsely populated areas. So especially important as case rate loads fall and enabling management in place of on-reserve First Nations. So the whole program is set up to be presupposed to provide equitable care, and so that's hard to do when you're dealing with such massive distances. As you just saw, you saw how big the province is. So the virtual clinic is really a colloquialism in the TB program in Alberta. It refers to a clinic that does not actually see patients face-to-face. Rather, it receives from community health nurses in reserve communities or public health nurses in rural health zones referrals in the form of a medical record and their radiographs, and you also have a telephone. You can speak to whoever, you can speak to the lab, but you don't actually have a patient in front of you. And public health nurses in the virtual clinic and in the communities are key to it all. And so there's a small group of nurses who actually are based in the virtual clinic, but then there's a group a small group of physicians in the province, 4 in Calgary and 8 in Edmonton, who basically provide all of the medical advice to these clinics, whether it be the 2 stationary or sort of traditional outpatient clinics, or whether it be the virtual clinic. And these are all university-based infectious disease or pulmonary physicians who've taken an interest in tuberculosis. And so all of them, these are the only 12 doctors in the province who actually prescribe anti-TB drugs, or for whether it's for active disease or latent infection, and all of the decisions that are made about treatment come from these 3 clinics. And I would emphasize that these are not university-based clinics, even though the physicians are university-based people. these are public health clinics, and so it's entirely a public health program. So, and in addition to recognizing the negative history attached to the removal of First Nations to distant sanatoria, it resembles, there was a chap by the name of Curry in the US who wrote a number of papers about this kind of clinic model. And so the model is not unique to Alberta, although the fact that these are public health clinics is unique. Most of the clinics in the US are basically hospital-based or university-based clinics, whereas in this model, the Public Health Department of Alberta Health and Alberta Health Services has basically really stepped up to the plate and funds this program. Now, I did mention, and it is key to the whole, well, this is just a chart of the way the program is organized. So you have basically these 3 clinics, 1, 2, 3. These clinics here are just standard outpatient clinics, but they're dedicated TB clinics. They happen to be, the one in Edmonton happens to be at the university. They're all specially ventilated. If you've got a complex patient in this virtual clinic, then they are referred to either of these stationary clinics. And then there's one in Calgary. And this is the virtual clinic, and it houses the TB registry, etc. And then up here you have First Nations and Inuit Health, and in Alberta, First Nations and Inuit Health contracts with the province for the delivery of TB services in their communities. They, though, continue to provide a lot of ancillary services, and we have a wonderful working relationship, the province and FUNIB, but FUNIB is indirectly funding a part of that virtual clinic because it's serving all of the reserve communities in Alberta. Just go on to the next slide. So the clinic has been, we think, very, very successful. This is a very rigorous age and sex adjusted incidence rates, and this is when the clinic was introduced in 98, 99, and we've seen a big drop in the rates in Indigenous peoples. These are registered First Nations. This red line, as you can see in Alberta, there has been no change whatsoever in the rate of disease in the foreign-born, and it relates to the amount of immigration there has been historically into Alberta right up until kind of October or late 2014 when the price of oil fell, but there was a huge influx. And in Canadian-born non-Indigenous rates that are approaching elimination of 4 per million. We've seen the success. These are just rates, again, quite rigorously calculated rates in on and off reserve registered First Nations in the decade preceding the introduction of the virtual clinic and in the decade following. So the blue is the following decade. This is the earlier decade. So we've seen big drops. Whether we can attribute it to the virtual clinic, I really don't think so. I think it's multifactorial, but we do believe the model has helped. The other, just before I close, the other major thing that we did was we decided we wanted to look carefully at the performance of the virtual clinic in comparison to these two sort of classical or conventional outpatient clinics. And so we looked at 28 different performance indicators. Many of them are indicators that the US uses. We added some more. and it all comes down to the quality of the data and whether you can consistently measure it across clinics. But we were able to measure these 28 indicators and compare the performance of the two clinic types. And when we did that, these were the results. Basically, the two clinic types performed equally well, and overall, the whole program performed very well. And so there were a few small differences, and where the stationary clinics were superior and the virtual clinic was inferior, and vice versa, but just a few. So we concluded that the outpatient and virtual public health TB clinic model clinics perform equally well in low incidence settings. Such a combination of the two clinic types has the potential to address issues around equitable service delivery and declining expertise. So I'm going to stop there, you guys, and perhaps if Andrea is on the line or Courtney, they will say some few things, because critical to this model is basically the public health nursing infrastructure. And I can't emphasize that enough. You have to have people out there who will be able to respond to the directives that the physician dictates in sitting in front of a computer in an office in Edmonton. And we use telehealth as necessary, but critical to it all is this nursing infrastructure, and I think Andrea will comment upon that. And if Courtney's on the line, she might comment upon some wonderful work she's doing around physician education. So, Elaine, I don't know if you're there.
It's Andrea here.
Oh, Andrea, sorry. Sorry, Andrea. Yeah, it's Andrea, go ahead and feel free to chat a bit about the nursing role.
Sure, I just did want to make a couple of comments. That virtual clinic model really looks at the virtual clinic staff as the experts in TB care, but really recognizes the frontline staff as the experts in community. And so it's looking at marrying those two pieces together and taking, the TB expertise as to what needs to get done, and the frontline staff really figure out how it can get done within the setting. And so those partnerships and relationships are so important, and they are really what drives the functionality and the success of getting the care done with and for clients.
And Andrea, I know we're both a bit worried about the fact that some of the educational activity that historically has been in place to support the nursing network has not been funded in recent years. Did you want to comment upon that?
Yeah, basically that because of the changeover in staff, it's important to have that continuity of education continuously happening. So NIB does it somewhat internally, but in order to keep that level of clinical, both clinical and community expertise within the TB program, it's really important that there is regular time for frontline staff to really concentrate or to focus on TB. And so part of that used to be some regular educational sessions, and also a provincial TB network of nurses, as well as every couple of years there was a big learning event that nurses were supported to come to. And so all of those things facilitated the maintenance of that TB network with nurses both on and in First Nations communities and out because of the migratory nature of clients in general. Just facilitated maintaining those partnerships and those relationships that really drive the activities that make TB programming successful. And so yes, we have definitely been, it has been a bit more challenging to maintain those relationships and partnerships just because there has been some cuts to some of the more organized ways to keep that functioning, and so, yeah, just, I guess that's where I'll stop.
Okay, thanks, Andrea. Thanks very much. Courtney, I don't know if you're on the line as well. Oh, okay. You're probably not. At any rate, you guys, what Courtney's been working on, Courtney's the manager of our research unit, and she's doing her PhD, and one of the things she's working on is being able to predict pulmonary TB. She's developed a very, very nice prediction equation, and it draws on 7 clinical rubrics. And we are going to be using that as a training tool eventually, because it's critical that as the numbers get down and you're trying to eliminate the disease, then people are not thinking about the disease, and that's just normal. That's human nature. It's not a diagnosis that's high on their differential. So there has to be a way, as we approach elimination, to basically prompt physicians to when to think about this disease. And we think we have the 7 key rubrics that should trigger your thinking of this disease and submitting sputum. And that's so critical to the timely diagnosis and the introduction of treatment in the incident case, but also, of course, interrupting transmission and eventually getting rid of the reservoir. So the 2 big, if you can think of TB elimination, there's basically 2 major things have to happen. You have to interrupt transmission, which means making early and timely diagnoses. Secondly, you have to basically remove the reservoir. And so her prediction tool is aimed at doing that, especially as numbers get down. So I'll stop there, you guys. Happy to answer any questions or